Question 1. Radiation safety and quality assurance. A hospital is evaluating its radiation safety procedures to ensure compliance with regulatory standards. One concern is occupational exposure for radiation workers. Which of the following measures is the most effective in minimizing radiation exposure for radiation oncology staff? A. Implementing mandatory lead aprons and thyroid shields for all staff in the radiation therapy room. B. Increasing distance from the radiation source and using shielding barriers where possible. C. Reducing the number of patients treated per day to lower total radiation exposure in the department. D. Encouraging radiation workers to undergo frequent medical imaging to monitor for radiation-related damage. Answer: B. Increasing distance from the radiation source and using shielding barriers where possible. Explanation: the ALARA, as low as reasonably achievable, principle states that radiation exposure should be minimized by using three key factors: time, distance, and shielding. Distance is one of the most effective ways to reduce radiation exposure because radiation intensity follows the inverse square law, i.e., doubling the distance from source reduces exposure by a factor of 4. Shielding, e.g. lead barriers, prevents radiation from reaching workers, significantly reducing exposure. A. Incorrect. While lead aprons and thyroid shields help in diagnostic radiology, they are not the primary protection method in radiation oncology where higher energy beams are used. C. Incorrect. Reducing patient load does not directly impact individual worker exposure if proper safety measures are in place. D. Incorrect. Frequent medical imaging does not reduce exposure. Rather, personal dosimeters should be used to monitor occupation. Question 2. Clinical radiation oncology. Thoracic malignancies. Which of the following is the primary advantage of using proton therapy over conventional photon-based radiation therapy for non-small cell lung cancer (SLCA)? A proton therapy provides superior tumor control by delivering higher biological doses than photons. B. Proton therapy significantly reduces radiation dose to surrounding normal lung and heart tissue. C. Proton therapy has been proven to improve overall survival rates in all cases of ESLC. D. Proton therapy eliminates the need for concurrent chemotherapy and locally advanced ASLE. Answer: B. Proton therapy significantly reduces radiation dose to surrounding normal lung and heart tissue. Explanation: proton therapy is an advanced radiation modality that uses charged particles, protons, instead of photons. Its key advantage is the Bragg peak effect, which allows protons to deposit most of their energy at a specific depth in tissue, sparing normal structures beyond the target. A. Incorrect. Proton therapy does not inherently provide superior tumor control in terms of biological effect. The relative biological effectiveness, or BE, of protons is approximately 1.1, similar to photons. C. Incorrect. While proton therapy shows dosimetric advantages, clinical evidence demonstrating a significant survival benefit over conventional photon therapy in LSSLC cases is still being investigated. D. Incorrect. Proton therapy does not replace the need for chemotherapy in locally advanced SLC. Chemoradiation remains the standard of care. Question 3. Scenario-based question. Palliative and supportive care. Dr. Simmons is treating 72-year-old male patient with metastatic prostate cancer who presents with severe pain due to multiple bone metastases. The patient's pain is not well controlled with systemic opioids, and he has difficulty walking due to metastases in the pelvic bones. What is the most appropriate next step in his management? A. Increase opioid dosage to maximum tolerable levels before considering radiation therapy. B. Administer single fraction or multi-fraction palliative radiation therapy course to affected bone sites. C. Prescribe bisphosphonates or denosumab as the primary treatment for pain relief. D. Recommends surgical intervention as radiation therapy is not effective for bone metastases. Answer: B. Administer single fraction or multi-fraction palliative radiation therapy course to affected bone sites. Explanation: palliative radiation therapy is a well-established treatment for painful bone metastases, providing significant pain relief in 60–80% of patients. It is particularly effective in cases where systemic analgesics are insufficient. Single fraction 8-GI-X1 and multi-fraction e.g. GI in 10 fractions regimens are both effective, though single fraction treatment is convenient for patients with limited life expectancy. A. Incorrect. While opioids are useful, escalating dosages alone without addressing the underlying cause, bone metastasis, is inadequate. C. Incorrect. Bisphosphonates e.g. zoldronic acid and denosumab help prevent skeletal-related events but are not the primary treatment for acute pain relief from bone metastasis. D. Incorrect. Surgery is reserved for impending fractures or spinal cord compression, not general management from bone metastasis. Question 4. Radiation safety and quality assurance. During routine quality assurance (CAR) procedures for a linear accelerator used in intensity modulated radiation therapy (IMIT), the medical physicist notices that the output of the machine has deviated by 3.5% from the baseline measurement. According to OPM Task Group 142 recommendations, what is the most appropriate action to take in this situation? A. Continue treatment as planned and monitor the deviation for the next few days. B. Immediately stop all patient treatments and recalibrate the machine before resuming. C. Continue treatment but notify the radiation oncologist and perform additional CAR checks. D. Perform a detailed investigation, assess potential causes, and determine whether recalibration or correction is required before proceeding with treatment. Answer: D. Perform a detailed investigation, assess potential causes, and determine whether recalibration or correction is required before proceeding with treatment. Explanation: according to OPATIJA 142 guidelines, an output deviation of 3% is considered within tolerance, but deviations beyond 3% require corrective action before proceeding. In this case, deviation of 3.5% is slightly beyond tolerance limit, necessitating further investigation before continuing treatment. Stopping all treatments immediately, option B, is unnecessary unless the deviation exceeds the action limit, which is typically 5%. Option is incorrect because continuing treatment without investigation could lead to unintended dose discrepancies. Option C is partially correct but lacks the necessary investigative step. Therefore, option D is the best response, ensuring patient safety while maintaining quality control in radiation delivery. Question 5. Clinical radiation oncology. Head and neck cancer. 62-year-old patient with TNM or oropharyngeal squamous cell carcinoma HPV positive undergoes concurrent chemoradiation with 70 GI in 35 fractions. The treating physician is concerned about long-term xerostomia and dysphagia. Which of the following best describes an appropriate organette risk or constraint strategy to minimize toxicity, maintaining tumor control? A. Keep the mean dose to the parotid glands below 26 GI and limit the dose to the superior pharyngeal constrictor muscles below 50 GI. B. Avoid dose constraints for the parotid glands since they are outside the primary target volume. C. Deliver an additional simultaneous integrated boost (SIB) to 77 GI in 35 fractions to improve tumor control. D. Use proton therapy to completely eliminate non-target tissues. Answer A. Keep the mean dose to the parotid glands below 26 GI and limit the dose to the superior pharyngeal constrictor muscles below 50 GI. Explanation: organette risk or constraints are essential in head and neck radiation therapy to minimize late toxicities like xerostomia and dysphagia. Studies such as Passport have shown that keeping the mean dose to the parotid glands below 26 GI significantly reduces the risk of severe xerostomia. Similarly, limiting the dose to pharyngeal constrictor muscles can help prevent severe dysphagia. Option B is incorrect because sparing the parotid glands, even if they are not in the target volume, can reduce xerostomia. Option C is inappropriate as increasing dose beyond 70 GI has not shown improved outcomes for HPV-positive tumors and could increase toxicity. Option D is an overstatement. While proton therapy reduces normal tissue dose, it does not eliminate it completely and is not always superior to MRT for head and neck cancers. Question 6. Systemic therapy and radiation oncology. A patient with locally advanced non-small cell lung cancer (SLCR) is undergoing definitive chemoradiation with 60 GI in 30 fractions. His oncologist is considering adding consolidation immunotherapy after completion of radiation. Which of the following is the primary rationale for this approach? A. Radiation-induced apoptosis of tumor cells releases neoantigens, which can enhance immune recognition when combined with checkpoint inhibitors. B. Immunotherapy directly increases radiosensitivity of tumor cells by interfering with DNA repair mechanisms. C. Consolidation immunotherapy helps in the immediate repair of normal tissues damaged by radiation therapy. D. The Pacific trial showed no significant benefit of consolidated immunotherapy in this setting. Answer A. Radiation-induced apoptosis of tumor cells releases neoantigens, which can enhance immune recognition when combined with checkpoint inhibitors. Explanation: the rationale for combining radiation therapy with immunotherapy in SLC is based on the concept of the The abscopal effect, where radiation induces tumor cell death, releasing neoantigens that enhance immune recognition. This effect is augmented by immune checkpoint inhibitors such as durvalumab, which was studied in the Pacific trial. The trial demonstrated that consolidation immunotherapy after chemoradiation significantly improves progression-free and overall survival. Option B is incorrect because checkpoint inhibitors do not directly increase radiosensitivity. Rather, they enhance immune-mediated tumor cell clearance. Option C is incorrect since immunotherapy does not play a primary role in repairing normal tissue. Option D is false as the Pacific trial strongly supports consolidation immunotherapy. Question 7. Brachytherapy. Cervical cancer. 48-year-old woman with stage E cervical cancer is planned for concurrent chemoradiation with external beam radiation therapy followed by brachytherapy. During planning, the dosimetrist asks about target dose constraints for high-dose RET HDR brachytherapy. What is the appropriate dose constraint for the rectum to minimize late toxicity? A. DCC 90J-ECT. B. DCC 75J-ECT. C. DCC 50J-ECT. D. No dose constraints are necessary for organs at risk in brachytherapy. Answer B. DCC 75J-ECT. Explanation: in HDR brachytherapy for cervical cancer, a key organ at risk or constraints are based on the dose received by the most exposed 2 cc of normal tissues DCC. According to guidelines from the American Brachytherapy Society (ABS) and EMBRACE studies, rectal DCC should ideally be kept below 75J-ECT to minimize the risk of late rectal toxicity. Option 90J-ECT is too high and would significantly increase the risk of rectal injury. Option C, 50J-ECT, is too conservative and may limit effective tumor coverage. Option D is incorrect as brachytherapy or constraints are essential for reducing toxicities. Question 8. Clinical trials and evidence-based practice. A large randomized clinical trial is conducted to evaluate the effectiveness of a novel radiosensitizer in glioblastoma treatment. The study has a primary endpoint of overall survival and a secondary endpoint of progression-free survival. What statistical method is most appropriate for analyzing time-to-event outcomes such as overall survival? A. Kaplan-Meier survival analysis with log-rank test for comparison. B. Student t-test to compare survival means. C. Chi-square test to evaluate response rates. D. ANOVA to compare survival between multiple groups. Answer A. Kaplan-Meier survival analysis with log-rank test for comparison. Explanation: time-to-event data such as overall survival and progression-free survival are best analyzed using Kaplan-Meier survival analysis. The log-rank test is used to compare survival curves between groups. Cox proportional hazards modeling can further adjust for confounding variables. Option B, student's t-test, is incorrect because survival data are typically non-normally distributed and censored, making parametric methods inappropriate. Option C, chi-square test, is used for categorical data, not survival analysis. Option D, ANOVA, is not suitable for time-to-event data as it assumes normally distributed continuous variables. Question 9. Ethics and professionalism in radiation oncology. A patient with advanced pancreatic cancer is referred for palliative radiation therapy for pain management. The patient expresses concerns about side effects and asks if there are alternative options. What is the most ethically appropriate response by the radiation oncologist? A. Proceed with treatment as planned, as the patient has been referred for radiation therapy. B. Explain the risks and benefits of radiation and discuss alternative palliative options, such as pain medications or nerve blocks. C. Encourage the patient to undergo radiation therapy without discussing other options. D. Refer the patient back to the medical oncologist without further discussion. Answer B. Explain the risks and benefits of radiation and discuss alternative palliative options, such as pain medications or nerve blocks. Explanation: in oncology, patient autonomy is crucial. Physicians must provide full disclosure of risks, benefits, and alternatives. The best approach, option B, ensures shared decision-making. Option it disregards patient concerns. Option C fails to provide alternatives. And option D is inappropriate, as the radiation oncologist should participate in the discussion rather than deferring to another provider. Question 10. Treatment planning. Breast cancer. 55-year-old woman with left-sided early-stage breast cancer undergoes breast-conserving surgery. She is scheduled for whole breast radiation therapy with prescribed dose of 50 J in 25 fractions. Due to concerns about cardiac toxicity, which of the following is the most appropriate strategy to minimize dose to the heart? A. Use deep inspiration breath hold technique during treatment delivery. B. Increase the prescribed dose to 60 Gi to reduce fractionation effects. C. Deliver treatment with an end-phase electron beam to minimize cardiac exposure. D. Switch to an anterior-posterior posterior-anterior APA beam arrangement. Answer A. Use deep inspiration breath hold DIB technique during treatment delivery. Explanation. For left-sided breast cancer, the deep inspiration breath hold DIB technique increases the distance between the heart and the radiation field, significantly reducing cardiac dose. Increasing the prescribed dose, option B, would not reduce cardiac toxicity. Electron beams, option C, are not appropriate for whole breast irradiation due to limited penetration depth. APAR beam arrangements, option D, would increase lung and heart dose. Question 11. Radiation biology. Fractionation effects. 68-year-old man with prostate cancer is treated with 36.25 Gi in 5 fractions using stereotactic body radiation therapy SRT. Compared to conventional fractionation, 78 Gi in 39 fractions. Which of the following best describes the radiobiological rationale for this regimen? A. Prostate cancer has low AB ratio, making it more sensitive to hyperfractionation. B. The shortened treatment course increases tumor repopulation. C. Normal tissues have lower AB ratio than prostate cancer, making them less sensitive to high-dose fractions. D. SRT is used only because of convenience and not due to biological considerations. Answer A. Prostate cancer has a low AB ratio, making it more sensitive to hyperfractionation. Explanation. Prostate cancer has low AB ratio 1.5, meaning it is more sensitive to large fraction doses than most normal tissues, making hyperfractionation an effective strategy. Option B is incorrect because short treatment courses reduce tumor repopulation. Option C is incorrect because normal tissues generally have higher AB ratio than prostate cancer. Option D dismisses the biological advantage of hyperfractionation. Question 12. Pediatric radiation oncology. Medulloblastoma. 7-year-old child with average-risk medulloblastoma is planned for craniospinal irradiation (CSI), followed by posterior fossa boost. What is the recommended CSI dose for this patient? A. 18 Gi in 10 fractions. B. 23.4 Gi in 13 fractions. C. 30 Gi in 15 fractions. D. 36 Gi in 20 fractions. Answer B. 23.4 Gi in 13 fractions. Explanation. For average-risk medulloblastoma, CSI is typically delivered at a dose of 23.4 Gi in 13 fractions, followed by a boost to the posterior fossa. Higher CSI doses, options C and D, are associated with increased toxicity. Low doses, option A, may increase the risk of recurrence. Question 13. Stereotactic radiosurgery (SRS) for brain metastases. A 60-year-old woman with 2 brain metastases, each 2 centimeters, from non-small cell lung cancer is referred for stereotactic radiosurgery (SRS). What is the typical prescribed dose for these lesions? A. 12 Gi in single fraction. B. 1820 Gi in single fraction. C. 30 Gi in 10 fractions. D. 50.4 Gi in 28 fractions. Answer B. 1820 Gi in a single fraction. Explanation. For brain metastasis, 2 centimeters SRS is typically delivered in single fraction of 1820 Gi. Low doses, option A, may be insufficient for tumor control. Fractionated radiation, options C and D, is used for larger lesions or critical locations. Question 14. ART for lung tumors. A patient with early-stage non-small cell lung cancer (SLC) is planned for stereotactic body radiation therapy (SRT) with a prescribed dose of 54 Gi in 3 fractions. What is the primary advantage of SRT in this setting? A. Increased dose escalation to improve tumor control while sparing normal tissues. B. Reduced treatment duration, allowing for faster initiation of systemic therapy. C. ART is better tolerated than surgery in all patients. D. No biological effective dose bed compared to conventional fractionation. Answer A. Increased dose escalation to improve tumor control while sparing normal tissues. Explanation. SRT allows for dose escalation while sparing normal tissues due to its precise targeting. Option B is the secondary benefit but not the primary rationale. Option C is incorrect, as surgery remains the standard for operable patients. Option D is false because CAR-T delivers a higher bed than conventional fractionation. Question 15. Adaptive radiation therapy. A patient undergoing radiation therapy for head and neck cancer experiences significant weight loss, leading to changes in tumor and normal tissue anatomy. What is the most appropriate course of action? A. Resimulate and replan treatment based on updated anatomy. B. Continue treatment with the original plan as minor changes do not impact dose distribution. C. Reduce the radiation dose to minimize toxicity. D. Delay treatment until the patient regains weight. Answer A. Resimulate and replan treatment based on updated anatomy. Explanation. Adaptive radiation therapy involves modifying the treatment plan based on anatomical changes to ensure proper dose delivery. Continuing with the original plan, option B, may lead to underdosing the tumor and overdosing normal tissues. Option C is inappropriate as dose reduction may compromise tumor control. Option D is incorrect as delaying treatment can negatively impact outcomes. Question 16. Proton therapy in pediatric oncology. A 5-year-old child with rhabdomyosarcoma is referred for proton therapy. What is the primary advantage of proton therapy in pediatric patients? A. Improved tumor control compared to photon therapy. B. Enhanced systemic therapy response. C. Reduced radiation dose to normal tissues and organs at risk. D. Shorter treatment time than conventional radiation therapy. Answer C. Reduced radiation dose to normal tissues and organs at risk. Explanation. Proton therapy reduces radiation exposure to normal tissues, minimizing late effects such as growth impairment and secondary malignancies. Option is incorrect as tumor control is comparable to photon therapy. Option B is incorrect as systemic therapy response is independent of proton therapy. Option D is incorrect as treatment times are similar. Question 17. Dose constraints for spinal cord nesia. A 67-year-old patient is planned for SRT, a spinal metastases at what is the maximum acceptable spinal cord dose in a single fraction SRT plan? A. 8 GI. B. 10 GI. C. 14 GI. D. 20 GI. Answer C. 14 GI. Explanation. For single fraction SRT to the spine, the maximum dose to the spinal cord should not exceed 14 GI to minimize the risk of radiation myelopathy. Lower doses, options A and B, may be too conservative, while higher doses, option D, exceed safe limits. Question 18. Brachytherapy for endometrial cancer. A 72-year-old woman with early-stage endometrial cancer is planned for vaginal brachytherapy after surgery. What is the typical dose fractionation for high-dose RET HDR vaginal brachytherapy? A. 7J x 3 fractions. B. 10J x 1 fraction. C. 25J x 5 fractions. D. 45J and 25 fractions. Answer A. 7J x 3 fractions. Explanation. HDR vaginal brachytherapy for early-stage endometrial cancer is typically delivered as 7J x 3 fractions. High doses in single fraction, option B, may increase toxicity. Options C and D are used for external beam therapy and HDR brachytherapy. Question 19. Total body irradiation TBI for bone marrow transplantation. A 42-year-old patient with acute myeloid leukemia or more is undergoing allogeneic bone marrow transplantation and receives total body irradiation TBI as part of the conditioning regimen. What is the primary goal of TBI in this setting? A. Enhance engraftment and eliminate residual leukemic cells. B. Provide localized tumor control in bone marrow sites. C. Reduce the need for immunosuppressive therapy post-transplant. D. Decrease the total dose of chemotherapy required for transplantation. Answer A. Enhance engraftment and eliminate residual leukemic cells. Explanation. TBI is used to eliminate leukemic cells and suppress the immune system to enhance donor cell engraftment. It provides systemic, not localized, tumor control, option B. EBI does not eliminate the need for immunosuppressive therapy, option C, or significantly reduce chemotherapy requirements, option D. Question 20. Radiation necrosis following stereotactic radiosurgery SRS. A 58-year-old woman with a history of breast cancer undergoes RS4 a solitary brain metastases. 6 months later, she presents with worsening neurological symptoms and MRI findings consistent with radiation necrosis. What is the most appropriate management approach? A. High-dose corticosteroids and close monitoring. B. Report SRS to the same site to control the necrotic lesion. C. Immediate surgical resection to remove the necrotic tissue. D. Whole brain radiation therapy to prevent further necrosis. Answer A. High-dose corticosteroids and close monitoring. Explanation: radiation necrosis is managed with high-dose corticosteroids to reduce edema and inflammation. Reper SRS. Option B is not appropriate for necrotic tissue. Surgery. Option C is reserved for refractory IBI. Option D does not prevent or treat necrosis. Question 21. Partial breast irradiation (PBI) versus whole breast radiation therapy. A 63-year-old woman with early stage ER-positive breast cancer undergoes lumpectomy. She is considering accelerated partial breast irradiation (ABI) instead of ABI. A primary limitation of ABI: A. Higher risk of local recurrence outside the tumor bed. B. Increased incidence of cardiac toxicity. C. Requires longer treatment duration. ABI. D. Limited to patients with triple-negative breast cancer. Answer A. High risk of local recurrence outside the tumor bed. Explanation: ABI treats only the tumor bed, increasing the risk of recurrence outside this area compared with ABI. Cardiac toxicity. Option B is not a major concern. ABI has a short treatment duration. Option C. It is not limited to triple-negative breast cancer. Option D. Question 22. SRS for arteriovenous malformations (AVMs). A 30-year-old patient is diagnosed with an arteriovenous malformation (AVM) in the left temporal lobe. SRS is recommended. What is the primary mechanism by which SRS treats AVMs? A. Immediate vessel thrombosis following radiation exposure. B. Progressive endothelial damage leading to vessel occlusion over months to years. C. Rapid reduction in blood flow due to radiation-induced vasodilation. D. Direct destruction of the IM via apoptosis of vascular cells. Answer B. Progressive endothelial damage leading to vessel occlusion over months to years. Explanation: SRS induces progressive endothelial damage leading to vessel occlusion over time. Immediate thrombosis. Option A does not occur. Vasodilation. Option C would increase blood flow. Apoptosis of vascular cells. Option D is not the primary mechanism. Question 23. Radiation pneumonitis following lung cancer treatment. A 72-year-old patient with steatomenon small cell lung cancer receives concurrent chemoradiation. 2 months after treatment, he develops a persistent dry cough and dyspnea. Aiken shows patchy ground glass opacities in the irradiated lung. What is the most appropriate initial treatment? A. Corticosteroids to reduce inflammation. B. Immediate oxygen therapy with mechanical ventilation. C. Antibiotic therapy for presumed bacterial pneumonia. D. Repeat radiation therapy to reduce the affected area. Answer A. Corticosteroids to reduce inflammation. Explanation: radiation pneumonitis is treated with corticosteroids. Mechanical ventilation. Option B is reserved for severe cases. Antibiotics. Option C are not needed unless infection is suspected. Repeat radiation therapy. Option D is contraindicated. Question 24. Spinal cord tolerance in conventional radiation therapy. A patient undergoing conventional radiation therapy for a cervical spine tumor is prescribed 60 Gi in 30 fractions. What is the maximum recommended dose to the spinal cord to minimize the risk of myelopathy? A. 45 Gi. B. 50 Gi. C. 55 Gi. D. 60 Gi. Answer B. 50 Gi. Explanation: the spinal cord tolerance in conventional fractionation is typically 50 Gi. Exceeding this increases the risk of radiation myelopathy. Doses of 55 Gi or 60 Gi, options C and D, are above the safe threshold. Question 25. Proton therapy for skull-based tumors. A 50-year-old patient with a skull-based chordoma is referred for proton therapy. What is the primary advantage of proton therapy in this case? A. Superior tumor control compared to photon therapy. B. Reduced radiation exposure to surrounding critical structures. C. Shorter overall treatment time. D. Increased sensitivity of chordomas to protons. Answer B. Reduced radiation exposure to surrounding critical structures. Explanation: proton therapy minimizes radiation dose to critical structures near the skull base while maintaining tumor control. Chordomas are not inherently more sensitive to protons. Option D. Treatment duration is similar to photon therapy. Option C. Question 26. Brachytherapy for cervical cancer. A 48-year-old woman with locally advanced cervical cancer receives external beam radiation therapy followed by brachytherapy. What is the typical total dose delivered to point? in high dose rate HDR brachytherapy A 45 Gi, B 60 Gi, C 8090 Gi, D 100 Gi. Answer C 8090 Gi. Explanation: the total dose to point equal per cervical area in HDR brachytherapy is typically 8090 Gi, combining external beam and brachytherapy contributions. Low doses options A and B are insufficient for tumor control. Question 27. Re-radiation considerations. A 65-year-old patient with recurrent head and neck cancer is considered for re-radiation. What is the most important factor in determining re-radiation feasibility? A. The time interval since prior radiation therapy. B. The chemotherapy regimen used in initial treatment. C. The tumor histology and grade. D. The presence of distant metastases. Answer A. The time interval since prior radiation therapy. Explanation: a longer interval since prior radiation therapy increases the likelihood of safely delivering re-radiation. Chemotherapy regimen option B and histology option C are important but not primary factors. Presence of metastases option D may affect treatment intent but not feasibility. Question 20. Treatment planning for parotid gland tumors. A 55-year-old patient with a malignant parotid tumor undergoes post-operative radiation therapy. What is the primary dose constraint for the contralateral parotid gland? A. 20 Gi, B. 30 Gi, C. 40 Gi, D. 50 Gi. Answer B. 30 Gi. Explanation: to minimize xerostomia, the contralateral parotid gland should receive 30 Gi. Higher doses, options C and D, increase the risk of severe salivary dysfunction. Question 29. Hypofractionated radiation therapy for prostate cancer. A 68-year-old man with intermediate risk prostate cancer is being evaluated for external beam radiation therapy (EBRT). His oncologist discusses the option of hypofractionated radiation therapy (HRT) instead of conventional fractionation. The patient wants to understand the benefits and risks of HRT. Which of the following statements best describe the rationale for using hypofractionation in prostate cancer? A. The AB ratio of prostate cancer is relatively high, making it highly sensitive to changes in fraction size, but HRT shortens treatment time while maintaining similar tumor control and toxicity rates compared to conventional fractionation. C. Hypofractionation primarily benefits patients with low-risk prostate cancer and is contraindicated for intermediate-risk cases. D. The increased dose per fraction in HRT leads to significantly higher rates of late gastrointestinal and genitourinary toxicity. Answer: HRT shortens treatment time while maintaining similar tumor control and toxicity rates compared to conventional fractionation. Explanation: hypofractionated radiation therapy (HRT) delivers higher doses per fraction over a shorter period than conventional fractionation while maintaining similar efficacy and toxicity profiles. The ABAB ratio of prostate cancer is low, not high, as stated in option A, meaning it responds to larger fraction sizes, which enhances tumor control without significantly increasing late toxicity. HRT is widely used for low and intermediate risk prostate cancer and is not limited to low risk cases. Option C is incorrect. Modern clinical trials PHA, Hypro, and ARTOG 415 have demonstrated that HRT provides comparable oncologic outcomes and toxicity rates compared to conventional fractionation. While higher fraction doses could theoretically increase late toxicity, careful dose constraints and advanced radiation techniques e.g. EMIT minimize risks to surrounding normal tissues, making option D incorrect. This HRT offers shorter treatment durations, typically 4-5 weeks instead of 7-8 weeks, while maintaining excellent disease control and acceptable toxicity levels. Question 30. Cardiac toxicity in left-sided breast cancer radiation therapy. A 52-year-old woman undergoes breast-conserving surgery for stage E left-sided invasive ductal carcinoma. She is scheduled to receive adjuvant whole breast radiation at Bohr with a prescription dose of 50 Gi in 25 fractions followed by a 10 Gi boost to the tumor bed. The radiation oncologist discusses the potential risk of card toxicity due to left-sided treatment. What is the most effective technique to minimize radiation exposure to the heart? A. Prone positioning to shift the heart away from the radiation field. B. Proton therapy to eliminate radiation exposure to the heart. C. Deep inspiration breath hold DIB to increase the heart-lung separation. D. intensity modulated radiation therapy IMIT to uniformly reduce heart dose? Answer C. Deep inspiration, breath, hold, dib to increase the heart-lung separation. Explanation: radiation therapy for left-sided breast cancer presents a risk of cardiac toxicity, particularly ischemic heart disease and coronary artery damage from incidental heart exposure. The goal is to reduce the mean heart dose (MHD) and minimize dose to the left anterior descending artery (LAD) while ensuring adequate tumor control. Why is the best option? Deep inspiration, breath, hold, dib is a technique in which the patient takes a deep breath and holds it during radiation delivery, which expands the lungs and pushes the heart inferiorly and posteriorly, increasing the distance between the heart and the radiation beam. Significantly reduces the mean heart dose (MHD) and exposure to the left anterior descending artery (LAD), lowering long-term cardiovascular risks. Is non-invasive and compromise tumor coverage.